Good afternoon, everyone. Thank you very much for coming. It is with pleasure that I introduce Niels from this institute here in Cambridge, who will talk to us today. The floor is yours.
All right, thank you very much. And thanks also for the invitation to speak here today. It's a great pleasure. So my name is Niels. I work at this institute. That's the Healthcare Improvement Studies Institute. We're based at Strange Ways laboratory just down the road. I'm going to talk about making predictions under intervention to avoid what I call causal blind spots in treatment decisions. So let me see whether this works. Doesn't.
No, it might be that you have to click on the window.
Yeah.
Okay. There you go.
That's fine. That's fine. Yeah. Okay. So before I start talking about that, let me tell you a little bit about myself. I actually only recently started here in Cambridge, a couple of months back in January. Before that, I was in Manchester for 10 years. Before that, I was in Amsterdam and I was trained in Utrecht in computer science and AI 10 years ago now. I wouldn't describe myself now as a computer scientist, I guess. I was trained like that. So I think my field is data science and health informatics. I work on clinical prediction models, electronic health records, healthcare quality and safety, and clinical decision support systems. When I'm not doing that in my free time, I do things like hiking goods, playing piano, and eating good food. So what are we going to talk about today? Prediction models. I'm just going to give a brief recap about what we mean by that. And then I'm going to spend on those causal blind spots. So basically what I'm going to argue is that if we develop prediction models and they are meant to be used to make treatment decisions, then we have to involve a form of causal reasoning. If we don't do that, and that's historically, traditionally how people do it, not think about any form of causality, I think you run into some causal blind spots, potentially giving the wrong information to the user of your model. There's two different scenarios that we then need to think about. One is baseline treatment. So treatment that is either given or not given at the moment that we are making the prediction, or what we call drop-in treatment, so treatment that would come in later on after we've made the prediction. And both obviously are relevant. And then I'm going to finish with some summaries and a take-home message. Just to acknowledge the people that I work with on this topic. None of the work that I'm going to present was done by myself in isolation, obviously. So here are some of the people, some of the key people who were involved in that. So one of my key collaborators in this space, Matt Sperrin, he's from Manchester, and others are Nan van Geloven from University Leiden, Ruth Fiog, Danielle Weer from Utrecht, and Angela here from Cambridge, from the cardiovascular epi unit. So prediction models, this is probably all familiar to you. If we have got some binary variable y that presents an adverse clinical outcome, then in prediction modeling, we're interested in predicting the risk that y is 1 at a particular time horizon t, conditional on baseline covariance x naught. And examples are, for instance, predicting the risk of hospital readmission within 30 days, risk of cancer recurrence with a different time horizon, 1 year, or risk of cardiovascular disease within 10 years. That's the running example that I'm going to use throughout my talk, risk of cardiovascular disease with a horizon of 10 years. So, as I mentioned, we always have this prediction horizon or prediction window. So there's a period over which we use things that have been observed, and they would all be included in x naught, and all that information is then used to make that prediction, and this is time 0. This is going to be important later on to understand the distinction between baseline treatment and drop-in treatment. Then every prediction model will go through a life cycle where we start with the data that are going to be used to develop the model. Then we do the actual modeling. we validate the model, and then we deploy the model. And typically what people say is once the model is proven to be valid or has been validated, we can deploy it in clinical practice. I personally think that's actually not right, but that's what you would very often see in the literature. And once it has been deployed, it will hopefully have some impact on clinical decision making, and with that also on outcomes. And that's obviously what we were trying to achieve. And then also traditionally, the way that these models are used to influence clinical decisions is via a threshold approach. So the rule is that if the risk is above a certain threshold, theta here, then we would treat, and the treatment is typically some preventative measure. And otherwise we don't treat. And the reasoning behind that is that the benefit, the harm associated with the treatment doesn't depend on the risk. It's something that is constant, essentially. There's always some form of harm with any form of treatment. It might be quite low, but it would still be there. But it doesn't depend on the risk, whereas the benefits of the treatment would depend on risk. So that means that there is some threshold above which benefits would outweigh harm. And if we manage to find that threshold, then we can do good by treating the people whose risk is above that threshold. So let me give you an example which you might be familiar with, which is called Q-risk. That's the model used here in the UK to predict the long-term risk of cardiovascular disease in people who do not yet have that. And there's been 4 iterations of this model. So the first one was published in 2007. And then number 3, which is what I'm going to use in the example, is from 2017. And just last month, the latest iteration, number 4, Q-risk 4, was published in a paper in Nature Medicine. The difference between number 3 and 4 is not massive, though. And yeah, my slides are just based on number 3, and I was lazy, so I haven't changed anything. So just to summarize, Q-risk 3, so that model predicts 10-year risk of incident ischemic cardiovascular disease. So that means having a heart attack or stroke in healthy individuals. It is used to decide whether or not to give people statins. And if the decision is made to do that, then basically you're going to take statins for the rest of your life. That's how it works. So the team who developed the model used a proportional hazard modeling approach to derive the risk equation. Data came from general practices in England. There was a split between derivation and validation practices. People included were between 25 and 84 years of age, free of cardiovascular disease, so they never had a heart attack or stroke. And also, they were not prescribed statins at baseline. That's important for the rest of my talk, so please remember that. Then there was a whole range of risk factors that were considered. There were separate equations for men and women, and C-index associated with those models were 0.88 and 0.86, so pretty good, actually, good model performance. And this is how Q-risk works. So this is from the web interface. You can try that at home if you like, or even during the talk if you like. The system, Q-risk is also embedded in the systems that GPs use. So they don't have to go to the website. They can just use it via their electronic health record system. But this is the one that I used. And I've entered here the information for Joe. Joe's a 50-year-old male. He's white. He's a heavy smoker. He's overweight. He's got type 2 diabetes. And he's got hypertension, elevated blood pressure. So it's probably a little bit small for you to read. But basically, that's the information that I entered here on the left-hand side. And then Q-risk says that the risk that Joe will have a heart attack or stroke in the next 10 years is 17%. So that's pretty high. And it's actually above the decision-making threshold. So the NICE guidelines recommend that GPs use this model, Q-risk. And if the risk is above 10%, then the guidelines say it's worth considering to initiate statin treatment. Obviously, with a patient like Joe, you would also have conversations about his lifestyle. But statins would definitely be on the menu for Joe. So, yeah. Okay. So Joe he had hypertension, but he wasn't yet on antihypertensive treatment. So we could consider to put him on that. So not statins or not just statins, but we could consider to put him on blood pressure treatment. So that's one of the tick boxes here. And now let's suppose his systolic blood pressure was 130. Let's assume that it would drop to 150, right? Let's see what happens. So now Joe's risk is 19.1%. It's unfortunate, say. I've got a question for you guys. What's going on here? So, are those pills not working for Joe? Or are the pills working, but somehow his risk is going up anyway? Or is the model not predicting what would happen if Joe were to be given blood pressure treatment? Anyone in the room who has an idea?
Be one of those.
Sorry?
It could be one of those. It's probably due to the spurious correlations.
Yeah. But
And also, that's not a causal model anyway. That's your setup there. So you change the blood pressure by taking the drugs, but that's not a causal model that you developed there to actually.
yeah, absolutely fair point. So basically, it is C, right? It is not predicting what would happen if we were to put Joe on blood pressure treatment. It's not a causal model. It's not intended to be used for this. And probably, I mean, we don't know for sure, but probably what is going on is that there's some unmeasured confounding. And I think that's probably, Joe has had previous spells of hypertension. He has it now, but his blood pressure, that's been high for quite a while. And that's probably the reason that his GP has decided to put him on that's the reason why GPs in the past decided to put similar patients on antihypertensive treatment. So that's an unmeasured confounder, and therefore the variable being on blood pressure treatment is actually increasing your risk. So there were two things happening here. I reduced his systolic blood pressure. That's associated with an actual reduction in risk, but being on this treatment is associated with quite an increase in risk because there's a selection bias going on. Interestingly, we know from conversations with GPs that some GPs tend to use a model like this. So they use it like this, for instance, for smoking. So they demonstrate to their patients, this is what would happen if you were to stop smoking. And they try to convince, it's a good idea to stop smoking. Now, fortunately, for smoking, the hazard ratio is actually smaller than 1, so your risk does go down. But obviously, it's not a full estimate of what would happen if you were to stop smoking. So it's not the right number that you get, but at least it does go down. In general, using a model like Q-risk in this way is obviously not a good idea for exactly the reason that Brian mentioned. But users, would obviously like to have a tool like that, and I can understand that because they're trying to make decisions. So we recently did some work exploring, what are the different scenarios where things like this can happen, where the fact that we develop these models without any consideration of causality can lead to effects, risk estimates that are at least counterintuitive. So we saw one of them, this one, but there's others as well. So for instance, in some studies, there's So the biobank is a good example. We know that, there's strong volunteer bias in the biobank, and that itself it's basically a collider, which can lead to some spurious correlations. So the example that we used is lifestyle and risk of getting cancer. And then we had a similar one for the COVID-19 networks. Again, there was a strong bias, for people who took part in that, and one open safety study where it's plausible that there's again unmeasured confounding via genetic factors, but then linked to mediator. So these types of considerations have in recent years led to quite a few papers who have said, when we talk about prediction modeling, risk prediction, we can't do that without taking causal considerations into account, without doing any causal inference. So there's a paper from Miguel Hernan from a couple of years back. We wrote a paper as well, and I thought it was better actually. But there's been a couple of people who've pointed out that prediction without considering causalities is not a very good idea. One of the arguments that also has been used is that if you don't do that, there's a risk that you run into what we've called the prediction paradox. So consider we've got a group of patients who have a high risk if no action is taken, say high risk of cardiovascular disease. And suppose we develop a prediction model, M1, and we develop it in historical data where no action was taken. So we find that for this particular group, patients X prime, they are correctly classified as high risk by the model. Now that model is now deployed in practice. So these patients start receiving an intervention and bad outcomes are avoided, which means that if we now fit a model to the data, again, to the new data, they would be incorrectly classified as having low risk because they have good outcomes. And if we then, deploy that model in clinical practice, obviously, those patients would be at risk of being undertreated. I haven't seen actual examples of this happening, but it's an example where not taking into account the causal effects of treatments could potentially lead to kind of cycle. We came together now 18 months ago in Leiden at the Lawrence Center at a workshop that was organized by Nan van Geloven from University of Leiden, Ruth Kiok from London, and Daniela Weir from Utrecht, with a group of people who are all interested in this topic. So the Lawrence Center is a center in Leiden that organized these kind of workshops. And we came together for and talked about prediction on interventional counterfactual prediction. And at the moment, actually, a couple of papers that were initiated and collaboration. It was really nice to be together for a full week with a lot of like-minded people who've been working on this topic, which is still relatively obscure, but I think is gaining momentum. And one of the papers that actually, I think, helped a lot of people, including myself, to think about this topic was a paper that was written by Nan van Geloven, published in 2020, which basically made explicit how we can incorporate causal thinking into the estimates for a prediction model. So historically, we don't do that. So if we look at the first row here of the table, the traditional approach is just to ignore treatment altogether, so it doesn't play a role in our estimate. It's slightly different here than the one that I used before. So we're here using survival model notation. But if we want to consider estimates for prediction under intervention, we're going to have to do that. So suppose that V would be the time to treatment start, then basically what we're trying to estimate, the things that we would like to estimate is, for instance, something where we assume that there would never be any treatment. And then we want to know what would be the risk of the event in question happening before time t, or where we would initiate the treatment now. And then obviously the difference between these two things would be the thing that we're really interested in, because it would quantify the benefit of treatment, initiating treatment now versus treating never. Obviously, what we would have to ensure if we want to estimate these things is that we have to assume exchangeability, consistency, and positivity. So just going back to the decision scenario that we saw before, and so in the traditional approach, we would base this decision purely on risk, on the risk threshold, whereas here we would focus on the benefit associated with the treatment. So we would treat if the benefits of treating the risk associated with not treating is higher than the risk associated with treating. Sorry, it's a slightly different notation than I had on the previous slide. But just a note on terminology. At that workshop, we had long discussions about this. So how should we actually call this? I think we started off with counterfactual prediction. That was also the name of that workshop. Yeah, we then considered, is causal prediction perhaps better, or prediction under hypothetical intervention, which is a term that I've used in the past. And I think we landed in the end at prediction under intervention, which I think is probably the best way to express what we're trying to do here. It's not really counterfactual because we're trying to predict into the future. So there isn't a factuality that we can ignore because things haven't happened yet. So I think counterfactual prediction is not quite what it is. So prediction under intervention at the moment, I think is probably the best term. But you will come across all these different terms in the literature.
Isn't this closely related to conditional average treatment effects? So on the last slide, you said treat if the conditional average treatment effect is positive. So in that literature, have they not, or where they typically estimate two predictions and then take the difference between the two of them, and that's the conditional average treatment effect? Have they not got a term for these two predictions of the counterfactuals, that they're subtracting one from another?
Not that I'm aware of it. But you're right. It is the conditional average treatment effect. Yeah.
It's fine.
Okay, so let's look at that distinction between baseline treatment and drop-in treatment. So baseline treatment is any treatment that would happen before time 0, so during the observation window, whereas drop-in treatment is treatment that happens after the prediction was made, so after time 0. I'm going to focus on baseline treatment first. We reviewed the literature a couple of years back to look at approaches to estimating the effects of baseline treatment in the prediction context. And we basically found that there were a number of different approaches. So the traditional approach is just ignore treatment altogether, but then condition on treatment in model, like I did in the Q-risk example. So we know obviously that there's issues with that. It's not the right approach. But it's the way that people have done it traditionally. Then one thing that people have suggested is to estimate separate models for the potential outcomes under treatment and lack of treatment using randomized clinical trial data. Another approach that has been suggested in literature is sometimes called the offset approach, where we take the causal effect, so typically the potential average treatment effect reported in RCT publications and add those to the prediction model as an offset. Then there's been some work on combining RCT data with observational data under a Bayesian approach. And the final approach is to only use observational data, estimated causal effects of interventions via inverse probability of treatment weighting. The one thing we also did is then did an empirical study where we selected 3 of these 5 approaches, not the 2 where you need access to individual patient level trial data, but the remaining 3, so not 1, 3, and 5, and compared them in a study where we had data from primary care from New Zealand, the PREDICT cohort. We had to use this cohort and we couldn't use UK data because we needed longitudinal data on lifestyle. And we typically don't have that in UK data, but this PREDICT cohort from New Zealand has that. So what we did in this study is use these 3 approaches and compare them to predict cardiovascular risk under 3 interventions. So smoking cessation, reducing blood pressure, and reducing cholesterol. For the latter 2, we also then use 2 different approaches. So one where we only modeled the effect of initiating medication, and another one where we modeled the effect of actually lowering blood pressure, cholesterol, which is obviously something else, and we will see in the results that makes a huge difference. And then in the IPTW analysis, we applied both a cross-sectional and a longitudinal approach. Let me show you the main results from the study. I'm leaving out a lot of the details here, but basically this is what we found. So here are the 3 different interventions. So smoking cessation, initiating blood pressure lowering medication, then actually lowering blood pressure, initiating cholesterol lowering medication, so that's statins, and actually lowering cholesterol. And then we have the traditional approach, or the non-causal approach, the treatment offset approach, where we use data from RCTs. In the case of smoking cessation, there wasn't an RCT, we had to use another estimate. And then the IPTW approach, it's the cross-sectional one and the longitudinal one. I'm going to focus here on blood pressure because I think that summarizes nicely what we found here. So if we take the RCT data here as our gold standard, then you can clearly see that only looking at the initiation of blood pressure medication is never going to give you the right answer via any of the other approaches. And that's probably exactly because, for the same reason as we saw previously, there's unmeasured confounding. And none of these approaches would obviously solve that. If you model the effect actually lowering blood pressure, it does get a lot better. And in fact, the non-causal approach isn't so bad. It's pretty close to what we know from RCT data, if we take that as the gold standard. What we hadn't expected, and which is probably mostly a power problem, is that the longitudinal IPTW doesn't perform very well and leads to an estimate that I think is too close to 1. We had expected that one to perform actually better than the cross-sectional approach, but in this example, it clearly doesn't. For cholesterol, the results are quite similar, actually. That was baseline treatment. Let's finish with drop-in treatment. couple of slides on that. So what's important to realize about drop-in treatment is that traditionally what's happened is that prediction models have typically been derived using a mixture of individuals who did and did not initiate treatment after time zero. So if we think about QRISK, for instance, in QRISK, the development cohort was people who were treatment naive. So they were not taking statins at baseline at the time of the where the clock starts, basically. But then for many of them, treatment was started thereafter, and sometimes quite soon thereafter. So that means if you look at their outcomes, that's heavily influenced by the treatment policy that was followed in the development cohort. So basically, the predicted risk is a weighted average risk under treatment strategies typically followed in patients having baseline characteristics X0 in a development data set and at the time that those data were collected. So that strategy might have been different than what we would do now. Right? If we go back 20 years, which typically is true for QRISK, things were quite different then than they were now, than they are now. In any case, this is something that users are very rarely aware of. And to be honest, even if they were aware of it, I wouldn't be sure what to do with this information because it's pretty hard to understand what this really is, right? And it's certainly not the thing you're looking for. Like I mentioned previously, you probably look for something like, what would happen if we did not treat this patient, and what would happen if we were to treat him. And then the difference between the two things is the benefit of the treatment. But this is not something that you need. Also important to realize is that obviously predicted risk will be lower than for untreated individuals with the same baseline characteristics. So there is here this risk that we would not treat people because their risk appears to be quite low, whereas actually that's because historically similar patients were always treated quite soon after time zero. So also for drop-in treatment, a number of estimation approaches have been proposed in the literature. So we've done some work in Manchester led by Matt Sperrin on marginal structural modeling, and there was a similar approach from Roman from Utrecht. And there's also been some machine learning work, actually from Cambridge, from Michele van der Schaar's group, on adversarially balanced representation. So this architecture actually from that paper, the BCAP paper. I mentioned that you're probably interested in something like what would happen if we would not treat this patient, and what would happen if we were to treat them, and the difference between those two things. Once you start thinking about this, you quickly realize it's actually a little bit more complicated than that, because that's never what would happen in practice. For instance, we would never decide now that we are never going to treat an individual. We would decide to not treat them now, but reconsider that in 6 or 12 months' time and keep doing that, and probably follow some kind of strategy. If this particular marker increases above a certain level, then we would probably treat. Conversely, if we decide to treat now, we would never decide that that's always going to be for the rest of their life. We start treatment now, but might reconsider that later on. So things are not so simple. So this was a long discussion at the Leiden workshop. It was really interesting. And in the end, we wrote a paper which is now under review, but I think it's almost there, and it's quite interesting. So that paper outlines estimates for dynamic treatment regimes. So in the paper, we make a distinction between point interventions. So those are treatments for a very short duration. So for instance, surgery, and sustained interventions, which are more common. So all long-term medication-like treatment, antihypertensives are sustained interventions. And there we can have a static regime, but like I said, in practice, what we I think always have is a dynamic regime. where the intervention decisions are based on some time varying health state of the individual. So in the end, what you would like to do is decide what are the plausible dynamic regimes, and then estimate or predict under those dynamic interventions, those dynamic regimes, what the individual's risk would be, and then make a decision. And that's it. So just to summarize what we discussed. So traditional prediction models ignore the effects of interventions, and I think that can lead to misinformed decision making. We've seen a number of examples of that. When prediction models are intended to inform treatment decisions, they're not always meant to do that, but when they are, I think they should be developed and validated using causal reasoning and inference strategies. They should specify upfront which treatment decisions they aim to support, and target a corresponding prediction estimate. And finally, the development and validation of prediction models should consider confounders, colliders, and mediators, as well as changes in treatment strategies over time. So I think it's a good idea, for instance, to always, drop a causal graph when you develop a model like this. That's not typically how people do it, but I think we should definitely move in that direction. And that's an idea which is picking up momentum, which is a good thing. But this is a couple of the key papers from recent years in this area. I'm happy to share my slides for anyone who'd like to have another look at them. And thank you for listening.
Are there any questions? Sean,
On one of the slides, you described this offset method, and you said that RCTs have been used to estimate the effect of a reduction of 70 units in blood pressure or something like that.
Yeah.
I was just wondering how that was done
In the trial or in the modeling?
in the trial. You happen to know how they did?
I'm not sure if I remember that, to be honest.
It's okay.
Um,
Curious.
What I do know is that, people have been doing this now for a while, this offset method. There's a really interesting paper written by Wouter van Amsterdam, who works in Utrecht, by the way. It's confusing, but he's called Van Amsterdam, about this method, which is actually, which explains that it's a little bit more complicated than it seems, because what you need in your model is a conditional average treatment effect. What you get from a trial is typically a marginal treatment effect. And that has consequences for when you use this model.
I suppose with clinical trials, the inclusion criteria makes you select a particular type of population also.
Oh, yeah. So in that study that I showed you, we used that more or less as a gold standard. But yeah, I think you have to be really careful with doing that.
In the New Zealand study, did they initiate statins after baseline as well?
Oh yeah, I mean, that happens all the time.
Okay.
Yeah.
In terms of the data that you use to model the things.
Yeah, because that's been a, I think, long-running cohort study where everyone who is screened for cardiovascular disease risk in primary care in New Zealand enters into the cohort. I can't remember now for how long it's been running, but yeah, it's been for quite a while. So there's definitely people who've been going through a number of cycles of screening for risk, and then at some point started statins.
Don't do some kind of correction for like inverse probability of treatment meet or something like that.
In their model.
Yeah.
No. So they they developed a model that's called PREDICT, which is a bit confusing because there are more models that PREDICT. But that's basically the New Zealand version of QRISK. And they ignore treatment in a similar way as Curious does. Yeah.
I think you mentioned two IPTW approaches. One was longitudinal, and the other one I forget what you said it was. Static, maybe, I don't know. What are those two methods?
So let me see if I can bring back that slide. Yeah. I think in the cross-sectional approach, basically in the cross-sectional approach, you don't really know whether someone has actually stopped smoking or whether they were just not a smoker. Whereas in the longitudinal approach, you know, you can focus on the people who actually stop smoking. So that's always a lot better. So I think those should be the more reliable, more accurate estimates. Like I showed in the study, that's not really what we found, unfortunately. But yeah, I would always expect the longitudinal IPTW to be much closer to the truth. I mean, the problem, as Brian mentioned, there's a problem with the truth here that, you know, that comes from trials, and whether that's representative for this population-based cohort, probably not.
Yeah, so you mentioned the Q-risk score being used by clinicians, and they sort of untick the smoking box, I guess.
Yeah.
And there's no history of smoking that's recorded within that tool.
No, I think so. GPs sometimes record whether people have smoke. I don't think they always do that, but it is a field in the GP records, and potentially it does have a longitudinal nature because, you know, it can change. I think the problem is that it's not systematically assessed, so we have no clue, you know, how reliable all of that is. And, you know, if people were to stop smoking, is that recorded? I don't think so. The difference with the New Zealand cohort is that they do this structured cardiovascular risk assessment every year or so. And then they really go through all these things. So they ask, you know, do you smoke? It's a new assessment of smoking. That's the reason that we went into that. So yeah, I think in the UK, it's not that it's not there, but I wouldn't trust the data collection.
We asked about that last treatment, actually lowering cholesterol. What is the actual treatment that they use to actually lower the cholesterol in a sense?
No, so there we compare people in whom the cholesterol went down versus people in whom it didn't go down.
But it could be that they went down just naturally.
Yeah.
It could be various different interventions potentially that could have caused that.
Yeah.
It didn't matter what kind of intervention.
No, we completely ignored medication there. We just looked at cholesterol values. Same story for blood pressure, and we compared people in whom it went down with people in whom it didn't go down.
When you say went down, is it over a particular period of time, or if somebody goes down and then goes back up, what do you do with those kind of people?
Yeah, good question. I can't remember that now. I'd have to look up the details. I think it was like a 12-month window, but you're right that there's many different scenarios. Although I think in the New Zealand cohort, people are assessed more or less regular.
Okay, so it's just that the first time they go, it goes down or something.
Yeah, when you're defining the treatment threshold, you define it as the threshold where the effect on Y is beneficial versus the effect on biosol. Presumably for the treatments, you're often looking at adverse effects on some other outcome, not Y itself. So presumably there's a balance there that has to happen. Some kind of clinical decision about kind of weighing up one possible adverse event against another.
Yeah. Yeah, I think you're right. I mean,
If you wouldn't expect statins to increase your risk of cardiovascular disease, but there might be a risk of some cancers or.
yeah, I think for statins, it's still relatively straightforward in the sense that there are some side effects. So muscle pain is one of them. Some people, that's pretty severe, so they stop taking them. So that's not really a risk. It's a side effect that makes people decide to stop using them, and that's not something I think you need to model. But you're right. In general, I would say you would always consider more than a single outcome. That's a different talk, and probably it's one for which you should invite Angela, not myself.
The risk.
Yeah, I mean, certainly in the long-term disease, long-term health conditions space that we're talking about here, as an individual, I'm not so terribly interested in my risk of getting a heart attack or a stroke. I'd be interested in the risk that I become ill. You know, whether that's cardiovascular disease or cancer or diabetes doesn't really matter in a sense. Just my general health is what I'm interested in. So all these different outcomes, and then yes, how can you reduce? What is the best course of action to reduce all those risks? Basically, that's ideally from looking at it from the perspective of the individual. You would like. That's completely different than how we do things now, because now we have a different model for each disease. Yeah. Yeah, and it is true that, you know, some things are just good for a lot of those risks. So physical activity is a good example. Reduce your risk for so many different things. Whereas most medication is fairly isolated. So if you look at that, if you take a more holistic perspective, you'd probably end up with slightly different decisions.
So I'm still thinking about the example you gave about a GP maybe untick the box of smoking and tell the patient that this is the risk you will have if you stop smoking. So yeah, I can see that this is not correct. But what if we say the interpretations that like retrospectively this would be the risk if you have never smoked? So, I mean, it seems, I mean, this message can still be conveyed like with this interpretation of the system if you just untick a box, right? And that's.
Yeah, but as a patient, what am I supposed to do with that information?
Yeah, maybe to regret and then.
I mean, if you were GP, you would do that. You'd basically be saying you have to get into your time machine, go back, and not smoke. Live your life again and don't smoke, and then you would be here. But that's tricky, right? We don't have that technology. But it's true. I mean, that's the interpretation of unticking that box. This is your risk if you had been someone else who never smoked.
There's one question online, and if anyone online has any questions, please feel free to unmute or type in the chat.
The meeting is configured to not allow us.
Please type in the chat then, and we'll fix that for next time if there are any questions.
Well, Simon has a question. I think any lessons to be learned for the design of RCTs to help improve prediction? Oh, that's a good one. Yeah. So I think where this field of prediction might be heading and this is actually something that occurred to me whilst I was preparing this talk, is that if we do, we systematically want to consider the causal effects of treatments in prediction models, then probably we would be moving towards a situation where we would always use trial data plus observational cohort data to develop the models. And so
How you do it?
anticipating, I think you could try to anticipate that you want to do that in the trial. I'm not a trialist, so I'm actually not quite sure how to do that. But yeah, I think it's plausible that we could be moving in that direction. So whenever you've got a new treatment, you'd have to do a trial. That's not going to change, but it would always be followed by population-based cohort study, and then the end result would be a prediction model that could do predictions under intervention. And if you know that that's going to happen, it makes sense, I think, to design your trial in such a way that you can do that easily, because it's always going to be pain, obviously, because that population-based cohort isn't going to match well to your trial. But perhaps there are ways to make sure that it's not so painful. But that's a reasonable answer to your question, Simon.
Can I ask something? At the beginning of the presentation, you showed a model that had several iterations, like a prediction model. What made them make those iterations? Like, what made them devise?
Yeah, it's a good question. So I think, and this is something I didn't mention. So this Q-risk model is also updated every year, where the parameters are re-estimated. So the structure of the model, the equation remains the same, but they use new data to re-estimate the coefficients. And they do that because we know that these models tend to be, become outdated quite quickly. Because things change, right? Populations change, diseases change, treatments change. So yeah, the world is changing all the time. Clinical practice is changing all the time. So you have to keep updating your model. But then, there's also more fundamental things going on where just re-estimating the coefficients is just not good enough. So then, so for instance, there are things that GPs didn't use to collect, but do collect nowadays, or have been collecting for the last 10 years. So chronic kidney disease is one example. That wasn't a thing, it wasn't diagnosed, let alone recorded. But since 10, 12 years, that definitely happens. So that's now something you can include in your model. So that's one reason that they, I think, then develop new models. I think also the size of the available data has just grown. So that gives opportunities to include more. I think these models have become increasingly bigger because, even though they do apply regularization, there's more data, so that's a slightly bigger model.
Is there a difference between how you need to refine prediction model and how you need to refine a causal model, or you follow the same principles?
Good question. I mean, chatting to Brian actually over lunch that, perhaps these prediction models with causal elements might be a little bit more stable than the purely associative prediction models. So you would expect that causal effects are less vulnerable to, if you get those right, you probably don't have to update them so often. So that might be a difference. I don't think we know whether that's true or not. So this is pure speculation, but that might be a difference. Other than that, I don't know. I don't think there's a huge difference. Although, if you develop your causal diagram, you probably want to redraw that. If you're redeveloping your model 5 or 10 years later, you probably want to redraw your causal diagram. It could be quite different based on new insights.
Thank you. There are no more questions online or inside the room.
There is one.
One possibly silly question, but I'm wondering if you're using just a causal model, for example, to do the risk prediction, would that make your risk predictions worse because you can't use some of them to estimate that risk?
Sorry, when you say just a causal model, what's that?
So when you're restricting to make your predictions based on, for example, causal variables, for example, if you're doing treatment effect estimation, you can't use all the variables to estimate the risk. You can
Yeah.
only use the causal. So would that make your risk estimate worse than if you were to use just the normal risk prediction model?
Yeah, to be honest, I actually don't know. Because this is also something that is, we've started on working relatively recently, and it's based, we're coming, we're approaching this very much from a risk prediction perspective. So we've got risk prediction models, they are being used to make decisions. We should look at the causal effects of the things that we're considering to do. And yeah, I think we're still at the start of the journey and we're not quite sure where we're going to end. And yeah, I mean, maybe at some point the purely associative risk factors might become less important. I don't know. Yeah.
You're thinking that some of these things might be proxies.
Yeah.
Or yes, for cause.
So for example, with the treatment, if you tick the box for treatment and that makes your risk greater, that's one of those things where it shouldn't, but it does. But that maybe makes the risk prediction better off.
That might be only your development data.
Sorry?
That might only be your training data.
Yeah, exactly.
Yeah.
So that's not causal.
You have a question online again.
Okay, from Stephen. Does it matter that prediction models often do not account for measurement error in parameters, either at development stage or in application? I would say that's a separate issue. Yeah, I think that's a separate issue. You're right that that's typically what we ignore in prediction models. We just entirely focus on point estimates. I don't think that, including causal effects into prediction models change that very much. I probably have to go away and think about it, Stephen, sorry.
Affect the uncertainty around the prediction.
Yeah.
But you might argue that you don't want to include the measurement error anyway, because it's the observed variables that you see in practice when you deploy.
Yeah.
Might be the case that, but then if you want to quantify the uncertainty of your prediction, then maybe it does matter. Sean probably knows a lot about this.
Oh, does he? Oh.
I would have said Ruth, but Ruth is not here.
Yeah, I'm just going to give you the same answer as you would have to think about that.
Given there might be meetings for the attendees, I say we give the speaker one more round of applause.